welcome everybody to the value-based payment conversation that we're having today. Our topic today, which is of great interest to all of us, is hot medical topics in medical home and primary care delivery reform. I'm Paul Grundy, Chief Transformation Officer at Innovacer, and I got dubbed the godfather of PCMH and the founding president of the Primary Care Collaborative, which helped lead the medical home movement. And with me today is Sean Martin, who is the executive director of the American Academy of Family Physicians and a passionate PCMHer. Rashika is the co-founder of IORA and was CEO there, and he's now in a new role, having merged with One Medical as the Chief Innovation Officer for the combined Rashika One Medical. And Ann Greiner is the executive director of the Primary Care Collaborative, and welcome all. The concept of the patient-centered medical home was first articulated by a guy named Cal Shia, a pediatrician in Hawaii. And what he was really talking about was a home for the data. He realized in the children with special needs that they were going to have multiple providers, that they were going to need to have schools involved, clinical counselors involved. They were going to need to have physicians and behavioralists. And what he realized quite quickly is your patients didn't get better if they weren't singing from the same sheet of music. So, he really began to talk about a home for the data, a home for where everybody could sing off the same sheet of music. And I think probably the transplant surgeons were the next group of folks that really understood that you had to have a multi-team approach to care. If your patients weren't going to die, you had to have somebody that understood immunology and transplant rejection and cardiac and surgery and et cetera. And back in about 2005, 2006, the American Academy of Family Physicians defined the future of family medicine and articulated the concept of medical home as the foundation of that. And so the next big movement that came along was accountable care. And what happened there was everybody sort of agreed that the foundation of care that was accountable, the move towards managing a population with data, with every patient having a plan, was fundamental and foundational and built on a relationship of trust in primary care. And that became the system integrator, the place in the system where accountability occurred. And of course, around the world, this has really taken off as well. I've spent a lot of time in England, Denmark, and Australia, and New Zealand. So it's pretty much universal. In fact, my most recent trip was to China, where we kicked off some pilots. We're now up to 127 pilots. So hot topics in medical home. Ann, I'm going to turn to you because I think you probably are the hottest in terms of keeping up with hot topics. But before I do that, I like to talk about the three legs of the stool. And it's really the cultural shift away from an episode of care to managing a population with data. That's the learning, that's the training, that's the education. It's the payment change. There's only one way to herd a cat, and that's to move the food. If you don't put the payment in the place where you want the service and you put it in the wrong place, you're going to get the wrong service. And the last thing, and I think that journey requires, is really the ability to have the data, a system of data acquisition that allows you to actually have a plan for every patient. And this journey has all three fronts. We're firing, all of our engines. But I think probably, Ann, where we're the weakest is in the payment change.
Well, thank you so much for that background. And also really my hat off to Paul for his leadership, along with folks like Sean Martin, who was there at the very beginning, to adopt this model from the pediatricians and bring multiple organizations together to advocate for its adoption by commercial health plans, by states, and by the federal government. And, I do think that it helped to foster a movement towards population health management, more proactive care as opposed to reactive care, looking at data to understand how we're doing in managing populations. It has brought about some cultural shifts. So there's a lot, I think, that we can be proud of in terms of what's been accomplished. And I think we see this in the peer-reviewed literature, particularly with respect to quality. But I think it is also the case that our aspirations for the patient-centered medical home or other models of advanced primary care have not yet been met. And I think you alluded to one of the fundamental reasons that we believe we haven't arrived at nirvana, which is we haven't done the reform of payment that is necessary to really support the patient-centered medical home or other advanced models of primary care. And in terms of payment, I think there are two really important aspects. Despite a lot of conversation and a lot of learning over the last 14 years since we've been working on this model, and in particular over the last 10 with a lot of work at the federal level through the Centers for Medicare and Medicaid Innovation and private health plans. And we've understand a lot more about what is necessary. I think that the payment changes have really, or the lack of payment changes have been an impediment. And most primary care practices are still paid fee for service. And what we really have come to understand is that that does not provide the kind of support for building out a comprehensive team to deliver a comprehensive set of services that we know can lead to enhanced population health outcomes, more equity in care, and actually eventually bending the cost curve. The other challenge that we've had is that primary care, despite all of the evidence, and check out the National Academy of Science, Engineering, and Medicine report that just came out in May, that it delivers with respect to, the triple or quadruple aim. We haven't been investing in primary care. And in fact, our proxy for investment, or the orientation of our health system to primary care, which is what are we spending on primary care as a percentage of total cost of care, is meager. In fact, abysmally low at 5 to 7% on the dollar, and has been shrinking. And when we think about the issues that we're facing as a country with respect to health, growing health inequity, patients not only having a raft of physical issues and chronic care issues, and basic chronic care management really not being in place to the degree we want it to be in place, and mental health issues and substance use disorder. And I could go on. The part of the health system that could be making progress in addressing those issues is underfunded, and investment is declining. And so, we very much believe in the patient-centered medical home model and other models of advanced primary care, but you can't do it on a shoestring, and you can't do it when you're in fact reducing investment while other parts of the healthcare system are taking up more of the healthcare dollar. And we're not getting healthier as a nation. And in fact, we're going in the opposite direction. So the Primary Care Collaborative has been focusing the last almost 4 years on addressing these very complicated problems, along with many other partners and the community at large. And we invite everyone on this call who wants to join with us to work on the knotty problem of how do we move to prospective payment and that team-based approach to care and a more comprehensive payment, and how do we get more investment in primary care to join us. More specifically, along with AAFP and many other partners, we've been working at the state level, where states who want to orient their systems towards a more primary care orientation have started to look at what they're spending on primary care. And these are across all payers except for ERISA. And what they found is that it varies by health plan, and it's quite low. And it has raised issues about, does our spending reflect our priorities and what we're trying to achieve? And bottom line, the answer is a big no. So 13 states are now reporting primary care spend. Half of them have set levels to increase spending to address the kind of issues that I think we all want to address: improve equity, address social determinants, address mental health needs, have a more comprehensive team that really is improving care. And we look at the NASM report and the recommendations in that report related to payment as a real opportunity to be working at the federal level to make the kinds of changes we see at the state level on the federal level to improve primary care, to move us to a comprehensive payment, and to get more investment in primary care so that we can realize these important gains for our patients.
So, Anna, I worked for years with the nation of Denmark, and over those years, we have now paid about 21% of total spend in care on primary care. That's resulted in almost 100 hospitals closing. And so we're not paying for butts in beds, we're paying to keep butts out of bed. And what we see is 93.7% of all care done at the primary care level. And I know, later on we can comment about it. I know that states like Rhode Island, who were one of the first states to really look at this and look at the Danish model, and now 12 others have followed, are beginning to invest more at the state level. Rishika, you actually have delivered this, right? I mean, you have a delivery system that's been focused on primary care and medical home, and you've just done really well. Would love to know what your experience is and sort of, what percentage of your spend is focused on primary care?
Yes, it's a great question. And thank you, Paul. It's great to be here. We have been in the real fortunate situation of, starting IORA as well as our now new compatriots at One Medical. And we both sort of said, let's start over. Like, there's a new vision for what primary care ought to be. And we had the great vision thing, let's start from scratch and build that vision out, and not start with what we have and start from scratch. And one of the pieces of it, I love your three, I call them three legs of the stool, the payment, the sort of culture, and the process and the technology, is you need all three of those things. Like a three-legged stool, if one of those three are not there, it falls apart. I actually think trying to innovate the care model in the absence of payment redesign is a waste of time. Yeah. So stop doing it, right? You have to do this. And again, I think Anne made a couple great points. And one is you have to get out of the episodic model. The job to be done, to quote, the late Grace Christensen, for primary care is actually population management. I think, unfortunately, when you're paid per visit or per click or per whatever, you think your job is you walk in the door in the morning, you have 38 patients booked, and you'll do the best job with each one, code as high as you can, then turn your brain off and go to the next one. That's not the right job of primary care. It's not why I'm a primary care doc, not why I went into this. What I really want to do is I have a population of people. I know exactly who they are, and they are my responsibility. My job is to improve their health and keep them out of trouble and do whatever it takes, and not have some bureaucrat say, we'll pay for this and not that. I get to decide. And the only question we have to ask is, will this help the patient? And that's just incredibly liberating, right? So the real thing is, one is stop the episodic payment, have a flat amount. There's some variants of that. Number two is, as Anne said, really double down on primary care. So primary care in general is 5 or 6% of healthcare spend. We think that number ought to be directionally 12 to 15%. So at least double. And our primary care models are directionally closer to 15 than 5 or 7. And now, by the way, you made this point very well, and this is where it gets a little tricky, is no one's generous enough to put more money into the healthcare system. But when everyone who's ever done this and invested in primary care the right way, you see huge drops in downstream spending. We see over and over again 40% drops in hospitalizations, 50% drop in ER visits, 35% drops in specialist costs. And it's all the right thing to do, right? Again, I love hospitals, but if you don't need to be in a hospital, you should not be in a hospital, right? They are dangerous places. Bad things happen to you when you go there, right? So really, we need to double down, and it's more than paid for through decreased downstream spending. I think, how have we done this? We've had a couple. We started, and One Medical started in the retail space, where you simply ask your patients. Direct primary care is sort of one of the terms of art for simply asking patients, we need to get funded a different way. Will you do this? And people pay, small membership fees. We then, and the industry then started, and that's how all of it started, right? Because in the beginning, payers wouldn't give us the time of day. As we got some evidence that this actually improved outcomes and lowered total spending, we started getting self-insured employers on the bandwagon. So we've worked with a whole number of self-insured employers. One Medical now has over 8,000 employers who pay at some version of a fixed fee. We work at IORA with people like the Boeing Company, Dartmouth College employees, the Washington Teachers Association. The self-insured employers are a great place to do this. They get it, right? That you do better primary care. By the way, the interesting thing with employers is it's not just better health, but it's better productivity. And that's another source of the savings. Third is we started doing this with Medicare Advantage plans. Medicare Advantage, we can go and we move to what's called full risk, where we as a primary care group take responsibility for the total cost of care. So now when we do better primary care and lower spend, we get to keep that and invest it back into primary care. And then finally, we're now, I think the really exciting thing is what's called direct contracting with the federal government. I think, hot topics is the federal government has now said, we're going to allow primary care practices to have these creative things in regular Medicare, right? So without having to go through an MA plan. And there are a variety of flavors of this, as you know. It's sort of primary care first, which is sort of a primary care cap sort of payment. There's a thing called professional GPDC, where you take sort of 50-50 risk. And then the track we're in, which is 100% global risk, directly with the federal government, with CMS, through the CMMI program. So these are really exciting, right? The payers are finally waking up and realizing that they're willing to do this. Now, unfortunately, people are caught in a little bit of a catch-22, where I think the payers aren't necessarily going to give you different payment if they don't believe you can execute on it. But many practices aren't able to execute on it because they don't have the right payment. And I think that's what we have to get over, right? And I think that's where partnership matters. The other thing, we're in this la la land where we started from scratch. For the vast majority of practices, the problem is they're stuck in this world where the vast majority of their payment, as Anne said, is fee for service. And now they want to go and you start getting a little bit of this risk payment or flat payment. It's really hard when you've got trying to do both. And I think the metaphor that people often use is it's like being with one foot in the dock and one foot in the canoe. I think the solution is we need to get multi-payer demonstrations, and we need to move not slowly into this new world. We have to move fast into the new world, right? And that's what it does. So again, payment redesign is incredibly important. That's what then allows you to make the investments you need up front in some of the technology and some of the process change.
Sean, you actually have the most cats to herd in terms of actually having the folks that deliver the care. And you've also spent a lifetime really in health policy in Washington. I would love to hear from you kind of how the members, the average family physician doc in towns around the United States are stepping up to this, and how that's being supported by the AFP and health policy changes in Washington.
Yeah, well, thank you, Paul. And it's good to see everybody again. It's good to see Rashika and Ann and have an important conversation. And I will say every time we have this conversation, I'm pleased that the ball is moving a little further down the field. It is getting better. And I, like everybody, each of you have been at this for a number of years. And it is important that we acknowledge that it is changing. There are changes afoot in the marketplace, albeit slow and albeit sometimes not the right changes, but there are changes. So I think, when we think about family medicine and the diversity of practices, it becomes really interesting to us. And it's not a a challenge. It's a challenge from a member service perspective, but it's not a challenge from a policy perspective. We take a little bit different approach. We have kind of taken an approach that primary care in all of its forms is a really good thing. And how can we best support those various forms? And Ann and Rashika both rattled off a number of different models. And I think it is, kind of a parlor game in Washington, D.C. and inside the insurance market to talk about which one of those models is better than the others. And I think the AAFP right now is just saying all of those things are good. There is value and transformation around primary care. And quite honestly, Barbara Starfield had it best. I mean, she just said there's value in primary care, and we need to kind of keep that front of mind. The function of primary care just has a value to the individual and population. So there's a few things I would kind of add. I mean, a little bit before our 2005 rendezvous, when we kind of started the modern day effort around the medical home, I think there were a couple of things that happened that were really important, although they were consequential in a very negative way to primary care. I think the collapse of the kind of managed care approach, was probably some lessons from that have been really impactful on the work we're actually doing today. And one of them, all three of you have touched on, which was kind of data democratization. I mean, it was, managed care from the physician's perspective was really challenging because they didn't have a line of sight into the information. The information was held by one party. So it was kind of hard to do population health and do the things they needed to do because they didn't have the ability to be reactive to the information that was available to them. I've said this not because I'm paid to do so, but I have, upon reflection, kind of gone back and looked at the Elliott Fisher and Mark McClellan work that they did for Brookings kind of around the time that ACA was passed, kind of coming into focus. And in retrospect, I think that work was really important. And a lot of people say that it led to the ACO movement. I don't know if that's, true or not, but I think what the Fisher-McClellan work really did is it brought into focus this concept of population health and really starting to take care of populations versus just individual healthcare. And it laid the groundwork in a very rough way for the kind of volume to value proposition that ultimately led us through a series of innovations that, kind of brought us CMMI and certainly brought macro law into focus and probably is the foundation that we're really working from today more than, any other kind of conversation and probably really, Paul and Ann in some respects accelerated the medical home because it kind of gave us a basis of population health to kind of work from in those early days. I want to touch on three kind of key things that I think are lessons learned and kind of where we are today. I think Rashika touched on this. We really have come, from my perspective, to a position of consensus that paying for episodes of services or episodes of time is really not congruent with primary care, that really we need to pay for the primary care function, whether that's the Barbara Starfield definition of that function or some modification of that. But the primary care function needs to be supported in a different way, and it's not a time-based or episodic-based model. It's a prospective payment model. I can't say it any better than Rashika just said it. It is a revenue cycle challenge to do innovation. 52% of family physicians are in some type of a value-based payment arrangement with at least one payer right now. It is hard for them to get all the way in. I think Rashika used the dock and canoe analogy. It's hard for them to all get there because you need cash flow up front to really invest in the process changes, culture, staffing that is required to really be all in. And the reason you see incredible innovation in primary care is because they are starting from a position of innovation versus working towards a position of innovation. They are just leaping forward through capital and investment, and they're able to start at a different point. And I always compare it to policymakers that will listen to me. If you went into a factory or a production line and said, we want you to stop making X and start making Y, you would have to shut down that production line, change the way you do it, and somebody would have to pay for that. There would be a cost to that. And in healthcare, we aren't really willing to assume that cost. We're always looking for, some type of miracle or disruptive innovation that would help us, identify that money that would pay for that cost. And I just think that's the wrong approach. I think it's an investment in the function of primary care, and that investment will pay off. So my third thing is probably a little bit controversial, but I'm going to say it anyway. And I think we approach primary care through the wrong lens. And I think primary care has been looked at for a long time as a solution to something versus its inherent good to individuals and populations. And I say that, we talk about like readmissions or reduced hospital admissions, and we all use these terms because that's an outcome of really good advanced primary care. But I think to too many people, particularly those with the checkbooks that are purchasing healthcare or purchasing primary care, they view it as a pathway to some other outcome, which usually results in savings. And I worry that that's the wrong approach, that really primary care is good for individuals and it's good for populations. And we should just pay for that, and we should put a value on that. And I think to both, Ann's point around investment, that's why the investment in primary care is so important, is the investment will ultimately pay off at some point in individual and population health, and then obviously in the healthcare system for the purchasers and payers further down the line. But I do worry about that. So I will just close with this. I think we are at a really unique point in time for primary care. I think COVID has given us an opportunity to think differently about community-based primary care and its value to the populations that it serves. And there are riddles that existed that have been solved because of a national tragedy. And I think the challenge for us is to really capitalize on those lessons learned and implement them in a more scalable way as fast as possible.
Sean, I'm really impressed with your comment about, an innate value. I think the innate value, if you look, I spent much of my time outside the United States in many cultures, but the power of the healer, the power of having a healer in your life when the chips are down are immensely important. I mean, it's built into the very function of our brain, right? Mm-hmm. We look for somebody in our life that can help us when the chips are down, right? And that role, that societal role, if the delivery system functions as primary care, it's as simple as that. And that trusted healer, that relationship of trust, has immensely important value. When we did some research looking at this from the large corporate thing, when we started all this, because we weren't happy with what we bought, if our employees were lucky enough to have a primary care as their normal source of care, they had a 19% lower mortality and they had a 23% lower overall cost, right? But the value was something other than that. The value was that relationship of trust that they had for their family with a healer in their lives, which I think is just immensely important. I think, the other thing is that another really hot area of conversation right now is the integration of social determinants of health and primary care. I happen to have spent some time in Iowa just prior to us not able to travel with the pandemic, and we had this upsurge of hospitalizations for our type 2 diabetics with hypoglycemic events. And I was sitting there talking to some of the physicians, and they were focusing on and looking at insulin levels, right? Playing with insulin levels. And when we began to actually look at the data, what we saw this was occurring in a few communities, areas, a few zip codes, and it was occurring at the end of the pay period. They were just running out of food. Mm-hmm. And I think that, kind of cultural understanding was just an important take-home message for me, is that, a relationship of trust with a healer in somebody in your life who is the system integrator, who is the primary care provider, who knows you. I think we can begin to look at and address those kinds of issues. Any thoughts or comments from any of you? And I know you guys have been doing it at IORA.
Yeah, I mean, so again, the key is, this is why you cannot focus on CPT codes and paying people per piecemeal, because there's no CPT code for ask people if they have food or even give them food, right? And I think when all of a sudden you think your job is not do stuff I'm paid for, but you think your job is improve outcomes, is heal, then you start asking questions. What will it take to heal this person? And that may well have something that has nothing to do with, quote, medical care, unquote. And you start, when you have access to the funding in a different way, you start solving those problems, whether it's giving people transportation or helping them with housing or helping them with food or any number of other things. And I think all of us who are doing this sort of full risk, this is what we do, right? So we have health coaches, we have 2 or 3 health coaches per doctor. We integrate behavioral health. We integrate social work because it's obvious, no doubt. If what you're trying to do is improve outcomes, that's what you have to do, and it's liberating, right? Again, it's not straitjacketing, and I think particularly with low income communities, that's what we have to do. Now, the dirty little secret, this is the problem. One of the problems is that this sort of invest up front to get better outcomes at the back end, that takes some time. It doesn't happen when you snap your fingers. And I think we have, unfortunately, some structures in place, like, in Medicaid, how people churn on and off because of structural problems, because of 1-year Medicare plans, because of, a number of quarterly profit earnings if you're a public company, that make it really hard to actually do the right thing and invest in a multi-year way. But who thought a year or a quarter is the right thing? This is about taking responsibility. I think that's why some of the places you talk about, Paul, like in Denmark, where these people are your problem for a lifetime, it makes it much easier to make those investments. It makes it, and that's why people like us work in Medicare. Because, by the way, once you're in Medicare, there's only one way out of Medicare, right? You sort of check out the other end. And so on Medicare, we can make those investments. On the commercial side, where people are churning jobs and churning health plans, it becomes really hard.
Absolutely.
I'd love to respond to your question because, Rashik, I'm a fan of what you've been able to accomplish at IORA. And I think there is, incredible innovation when you have this different payment model and you're thinking about how do we really maximize population health outcomes and how do we get creative in how we use those dollars to do that, and what kind of team do we need and what kind of interactions. And all of a sudden, the innovation that exists in primary care, and it is it's a really innovative part of our health system because it's so dynamic in response to what population needs are, is unleashed. I would also say that looking at some of the Green Center data, and this is a regular survey of primary care clinicians, and we've partnered with them on that, is that despite the lack of payment, what we saw is incredible responsiveness on the part of primary care, true professionalism to be responding to patient needs related to food insecurity, mental health issues, housing insecurity. The data shows that primary care, despite, no payment for it, was figuring out how to address those needs, because during the pandemic, we're still in the pandemic, but in the real throes of the pandemic, those needs were so intense. And you have a workforce that cares so deeply about their patients that even without the payment, support, they were doing that. So damn it, why can't we get the policy to really support that kind of spread? Because you've got an incredible workforce in terms of their connection to the people that they care for and their responsiveness to community needs. So that's the challenge for all of us and for policymakers who may be tuning in today.
It gives me goosebumps to listen to that, Ian. And I know from my time out there working in these smaller towns and helping some of the primary care docs that they're just so committed. But if you don't put the food in the right place, they burn out. I think Sean can talk a little bit about that, and perhaps Rashika as well. But when you're asking them to do a lot more than they have the team for, and again, this is a team sport, right? We all know that we do better when we have a clinical pharmacist supporting us and a behavioralist, et cetera. But But to do that, to have that kind of a team and deliver that kind of care without that payment, it's really hard. Sean, your thoughts on that and what you've seen?
Yeah, I mean, this is a dissertation, Paul, so I'll kind of boil it down to a couple of thoughts. I mean, I think we always think about, fee for service through certain lights. And I think one of the important things to think about with fee for service is just the irreparable harm it did to how we approach patients. So it took the brain out of the body, it took the mouth out of the body, it took all these different aspects of kind of comprehensive health away from the human in front of you. So, Rashika looks at a patient and it's like, well, I can't really, deal with your brain today because I'm dealing, with your organ systems, and you'll have to come back next week and we'll have a brain visit. And, because fee for service just created this weird culture of how you had to go about your day. And a lot of that was driven, to maintain operations. I think, Rashika, you said something earlier, like you just had to bill for services to keep, your practice going and meet your overhead and things of that nature. And I think the opportunity that we have is just to get away from that, acknowledge that that was wrong, create a prospective payment system that allows physicians to do what they need to do in the moment, if anything at all, and then lean upon other members of their healthcare team to do things to provide comprehensive and continuous care. And I love telehealth. I think, we went from like 23% of family physicians doing some form of telehealth to like 95% in a 2-month time period in 2020. It was one of the most incredible things I've ever witnessed. I mean, just as the adoption rate, it moved the telehealth debate forward a decade. But there's still some problems with it because sometimes you didn't need to do telehealth. Sometimes you just need to call somebody. And I think the thing that we're all striving for is a payment model that just allows the physician and the care team to do what's necessary to provide care to that patient or that population, and not what's necessary to, create a sustainable financing model for their practice moving forward. And I know a lot about the early days of IORA because I studied it in an academic setting. And, all Rashika really said to Dartmouth was, I'm going to open an office over here just right off campus. Just come by. I don't care. If you're sick, come by. If you're not feeling well, come by. If you're just walking down the block, just come by. Like, we're going to take care of all of you like it's a kitchen table. And I think it was just, first of all, well ahead of its time. But I just think that approach of just come by and we're going to take care of you is really what we need to strive for. And I'm circling back to a lot of different threads here, but the payment model doesn't do that. The payment model actually disincentivizes that in many, many ways.
Well said. I had the privilege of visiting small towns over a period of some years. Lynchburg, Virginia, Middleton, Tennessee, Alexandria, Louisiana. And what I did in those towns was approach the primary care providers there and hook them up with the employers. And in these towns, the employers is the county government, the school board, the Ford dealership, right? Those are employers that never move, right? They're going to be there forever. And in some places, it's even the hospital as an employer, right? Those entities, and I was really, and then directly contracting with the family physicians in those towns the primary care providers in those towns to deliver care. It changed the dynamics just tremendously. In Alexandria, Louisiana, O'Malley Lumber, I think, was the company that started it off. They literally changed the dynamics of how the hospital worked in their community. It was just phenomenal. But Rashika, you mentioned that One Medical and IORA are doing that. They now have about 800 direct to employer contracts. Is that changing the paradigm? Is the payment system working out better and that support mechanism working out better in those kinds of relationships? Is there hope there?
Absolutely, Paul. And I think you're exactly right. And again, there are a lot of aspects to it. So one of them is it just takes a lot of, it's one of my favorite quotes is from Michelangelo. And they asked him, how do you get this beautiful sculpture, the Pieta? And he said something very profound. He said, I take a block of stone and I chip away everything that's not the Pieta. Right. And I think we've spent too much time in healthcare adding more crap on. And what I think we need to start taking stuff away that doesn't add value. And all this sort of 99213, 99214, you have to check off 12 of these and boxes and 4 of these doesn't heal people. It gets in the way. And so, our arrangements, you mentioned Dartmouth, Sean, no bills, no codes. Once a month, there's a one-line email. We have this number of patients. You agree to pay us Y amount per month. Send us a check. Right. That's it. It is just hugely liberating, right? To get all that junk off the plate. The second one is this sort of direct contracting, as you mentioned, Paul, where the employer and the primary care provider now have a direct relationship. So you can start addressing really interesting things which go upstream, right? So we took care of the casino and hotel workers and the maids in Atlantic City, and they all came in with back pain. So we were able to call them in and ask, why are you getting back pain? They said, well, because of our jobs. We've got these short handle tools. We lean over the toilets and have to clean it. We have to make these huge beds. And then you ask them, how do you fix it? Oh, give us long handle tools. Let us work in teams. We could do this. And then we can go right to the employer and say, look, you idiots are paying $2 million a year for back pain treatment. If you actually change the job, we could avoid all of this stuff. Like, why don't we do that? Like, great, let's do that, right? So I think there are lots of benefits to this sort of direct contracting, simplification, and just say, let's take care of people. And what's great about these small towns, as you said, is no one's going anywhere. These workers aren't going anywhere, and these employers aren't going anywhere. We're stuck with each other. So let's actually think long-term and fix these problems from the root.
And Sean, from the policy side, and Ann as well, to both of you, do you have some optimism of, given as we come out of the pandemic, do you have some optimism of change that's going to impact and decrease the burnout rate and a hope for a better primary care foundation in our country?
Boy, that's a lot. Ann, do you want to?
I was going to say, you go first.
Okay. So I do. I mean, 2 key points on the burnout. In a more serious tone, I worry that we are on the leading edge of a burnout pandemic, particularly amongst the healthcare workforce, whether it be physicians or nurses or others. I don't think we quite comprehend the experiences, the lived experiences of the healthcare workforce in many communities around the country and what that impact's going to be. I mean, we get some one-offs, but I think we're a year away from really understanding what that is and the impacts and responses that we will have to have accordingly. I am optimistic, and I'm optimistic because one, it's nothing against academics, but our experiences from the pandemic are not published papers in fancy journals. They are things we all witnessed with our own eyes. Some practices closed because they couldn't support themselves. Some practices stayed open. Some grew. Some were more successful than others. I think these lived observations of how primary care flourished and what were the contributors to that, and sadly where primary care struggled, are real life observations that are more actionable than a group of talented researchers writing a journal article. I think that's hard for people to comprehend because they didn't see it. So I am optimistic for that reason.
And Ann, what are you going to publish in the outcomes next year?
Well, 2021, in partnership with the Graham Center, our report is going to look at the county level, the interaction between primary care, public health, and social assets, and how what's the relationship of those important factors and mitigation with respect to COVID, so infections and deaths. So stay tuned. That report's going to be out next month. But to Sean's point, I think that one of our lived lessons is that fee-for-service was really problematic when we had this, the work from home, stay-at-home orders. And, revenue plummeted. And so I think practices got a sense that, it's not the best payment model in these kinds of circumstances. and kind of, I think, maybe limbered practices up to think about different ways to get paid. Then they pivoted like a nanosecond in terms of telehealth, and their innovation bones got strengthened. A recent Green Center survey, 47% of clinicians said that they want to move to prospective payment, predominantly prospective payment.
Wow.
So, that's kind of from the clinician standpoint. This administration and many policymakers really want to close equity gaps, want to address mental health, want to address the social issues and vulnerabilities that were laid bare by COVID. How will they do that? Well, they got to go. I mean, I believe, and I think you all would probably agree, we do that by building this foundation of primary care and making it much more robust. And I think there are a lot of receptor sites in terms of policymakers, and I also think that primary care clinicians are ready for change and are showing a tremendous amount of leadership and really putting out a whole set of ideas. So I'm really optimistic.
And we have about 3 minutes left. And Rashika, I'm going to ask you what Barbara Starfield would think about what you're doing now in the combined One Medical and IORA, and where you're going with that, and how you're going to make a difference.
Yes, I would like to think that she would love it, right? That I think she was very prescient writing about this stuff, decades ago, when no one else was really talking about it. That we need different models. We need to base primary care on relationship and continuity and comprehensiveness that her sees. And I think the advantage we have is we now finally have payers slowly, but largely the employers, some of the MA plans, the federal government, shockingly, willing to pay differently, right? And I think there are enough of us creating some proof points for that. And then number two is that we didn't talk about technology at all, but I think the technology is now making it easier for us to do these, to engage with people through telemedicine. Telemedicine used to be these expensive $10,000 boxes you had to buy from Cisco. Now you give someone a $99 Android tablet, and you can do high definition video with a couple of clicks. The sort of population management tools that you know very well, Paul, are much, much better to be able to monitor this for people. So I feel very optimistic. I think if Barbara Starfield, were looking down, she'd say, this is actually exactly where we would need to go. It's still, the future is already here. It's just unevenly distributed. It is unevenly distributed. But hopefully I feel more optimistic than I have in a long time that we're moving in the right direction.
To the technology point, I honestly think that as we've tracked this out now for the past 15 or 20 years together in our journey towards delivering change, is that data has reached a point where it's going to do for the doctors' minds and their practices' minds what imaging and x-rays done for their vision. It's going to make it clear what you need to do for your patients, whether they're in front of you or not in front of you. And I think that's an exciting breakthrough. I mean, it's just phenomenal what I've seen happen in the ability of taking machine learning and AI and integrating that into the way Amazon shops you, but how we manage healthcare. It's just, I think it's exciting. Thank you all for attending this hot button issues in medical home, and delighted we could spend some time together.